Tissue Integrity, Introduction to Nursing Concepts. This is Martha Olson. We will be using the Swearingen book, the Manual of Medical Surgical Nursing, and also the Potter and Perry chapter 48 for this chapter. When we look at people that are high risk in our neighborhood, we know that there are many. Our diabetics that are out there. This is a 65-year-old woman that's going to be our diabetic for this unit and activity. As we look at Mrs. James, we know that she lives at home. She's a widow and very socially isolated. Coming prepared for the in-class activities, we will be talking about her medications. Glucotrol is for her blood sugar. Captopril, you see the end of that, it's an ACE inhibitor. It ends in pril. Digoxin is a cardiac glycoside that is will slow and strengthen her heart because she has a condition with her heart called atrial fibrillation. And then she also takes Coumadin for the atrial fibrillation that is kind of a blood thinner to keep her from making clots in her heart that is fibrillating. She has allergies to penicillin, which is an antibiotic. Socially, she's a smoker. And so we'll talk a lot about what the smoking does to her vessel size and why that precipitates the wound and tissue integrity that she has, as well as her risk for stroke and some other things that she has. She relies on friends for transportation and doesn't get a lot of exercise, unfortunately. This is what the bottom of her leg looks like when she decides that she needs to seek help. She finds somebody at the grocery store that says, oh, put butter on your wound and that'll help it heal. That's what my grandmother always told me to do. And as we will be learning in this unit, that was not very good advice, and that lower leg then continues to get worse for Mrs. James. You can see the redness around that wound. It's got an open area. The reason that we see a lot of problems to the lower extremities in your diabetic is that poor circulation, the further from the heart that it is. Our pathophysiology is totally related to all the things that are going on with her. In the older adult chapter in the Swearingen Medical Surgical book, we see that her smoking decreases circulation, and our nursing diagnosis that goes with that is our risk for impaired skin integrity related to lower peripheral capillary networks, secondary to age-related changes in her integumentary system. The smoking that we see lends itself very easily to the nursing diagnosis called impaired gas exchange, related to decreased functional lung tissue, secondary to her age-related changes. Age is another factor that we need to consider. Her risk for infection related to age-related changes in her immune and integumentary systems. With age, we also see suppressed inflammatory response secondary to long-term medication use, poor nutrition, and slow ciliary response. So as a recommendation for her, we would want to collaborate with the other people on the team, including the dietitian and the doctor and maybe the woundostomy nurse that is going to be working with her. As a nurse, I always think, with the diabetic, if we can prevent those wounds with good blood sugar control, because remember the sugar that's in her blood that her cells are not able to use because of the diabetes lends itself to any tissue that has problems. The sugar just feeds into that, just like we talked about in the urinary unit with precipitating the urine in the bladder to cause urinary tract infections. For glucose control, it's obviously her diet and her meds, and she takes the oral meds, not the insulin at this time. And then for lifestyle changes, quitting smoking and exercising will be important for her. And lastly, as we look at Mrs. James, we know that there is a chapter in the back of the Swearingen Medical Surgical book that's called Managing Wound Care. She will be the part where we look and read about the healing by secondary intention. Your primary intention is your surgical, a nice straight wound that's done under sterile conditions, but because of the nature to this wound, it is a secondary intention and will be much harder to heal and take a lot more time as we do that. Risk factors that are talked about in that book, she hits many of them. She's at the age where her circulation is not as good. She's a poor controlled diabetic. She's a cigarette smoker. She has some obesity issues with lack of exercise. And then I think she has some nutrition or malnourishment conditions as well, because she lives alone, doesn't have access to the store very often, and so you might wonder, what is her diet like? So in looking at maintaining skin integrity, we know the function of intact skin is to protect. It's that first barrier that we have. Many factors can increase that risk. Some of them include, not having intact skin is an obvious one, but other things such as very thin skin, very poor circulation, people that scratch their skin or have very dry skin and it cracks easily. Our stages of pressure formation we will look at, and then also look at the healing of both primary and secondary as well as burns. So our intact skin has 5 layers. We know the epidermis is the top, epi is on top of. It's our largest organ, our primary defense against infection, and the skin can cool down when the body temperature rises by radiation, and you know that because we sweat when we need to get rid of that extra heat if we're walking fast or working out. When the temperature drops, the blood vessels actually constrict and the production of sweat then diminishes. The physiological function of the skin is to provide protection. It's our thermal regulator. It gives us sensation and it protects us against any physical or chemical injury as a result of that. Our layers of skin, as I said, the epidermis is on top. Those are cells that become cornified as they filled with that waterproofing protein called keratin, which hardens over several days. We have different levels of epidermis. It is very superficial. It's avascular, meaning it doesn't bleed. And so if I would fall and scrape my epidermis, I shouldn't have a bleed. It's going to hurt a lot, but it will not bleed. The dermis then is just below that layer, and it's our blood and lymph vessels. It's got nerves and nerve endings, and so you would bleed if you fell and damaged the dermis. The dermis actually means tissue or skin. Our subcutaneous area then is below that dermis, and it's to help insulate. Some of us have a little more subcutaneous layer than others, and you know that because people that are very thin are cold in the winter, and people that are very heavy with subcu tissue oftentimes are much more comfortable in the winter here in Iowa. It comprises an outer normally fatty layer and then an inner thinner elastic layer, and between those 2 layers then is superficial blood vessels, nerves, lymph, mammary glands, and some other parts in different parts of the body. It's a storage deposit for fat. And this is where our insulin, when we give a subcutaneous insulin injection, is given down into this area. So looking at our knowledge, the avascular layer is going to be the epidermis. The layer that contains some muscle and nerve is going to be the subcutaneous or dermis layer. And the sweat and sebaceous or oil glands then is going to be in the dermis layer. So in a just quick review, the skin is the largest organ. It's about 15% of the body weight. It's the barrier for the body, and when that barrier is broken, we have an increased risk for infection. As a nurse, Potter and Perry tells us our job is to assess, to monitor the integrity, to identify problems, and then come up with nursing interventions that fit with the condition that they have. This ends our Unit 1.